So with no further ado, I'm going to introduce our first speaker, Dr. James Leverenz. Dr. Leverenz joined the Cleveland Clinic this past January, assuming the directorship of the Cleveland Neurological Center for Brain Health, and he has the Joseph Hahn, MD, Endowed Chair of the Neurological Institute. He received his undergraduate and his medical education at the University of Washington in Seattle. He then flew to the East Coast and received his neurological training at the New York Hospital Cornell Medical Center, and then he decided to try out the Midwest, and he went to Chicago, where he did a neuropathology fellowship, and then he moved back to Seattle. Cleveland has convinced him to move back here to the Midwest, and he has assumed the directorship of the Cleveland Neurological Center for Brain Health. His clinical and research interests are the age-associated neurological disorders with a particular focus on Alzheimer's disease and Parkinson's disease. So please give a little hand for Dr. Leverenz, and I think you'll all enjoy his presentation.
Good morning, and thank you, Barbara, for the nice introduction, and to Montefiore for the invitation to come and speak this morning. And I'll quickly move ahead. I think an overview of what I want to talk about, a little bit of an introduction to the epidemiology of dementia and to some definitions. A specific overview of Alzheimer's disease, because I think that's very relevant to understanding, especially some of the newer treatments, to understand the biology of what we know about Alzheimer's at this point. And then we'll talk about some current and some future treatments as well. So my patients often ask me, how can I keep from getting Alzheimer's disease? And I think this cartoon addresses that issue. You shouldn't worry about turning 21. I had an uncle who lived to be 21. The mouse says to Garfield, he says, really? I remember what he always used to say to me. What was that? Who the heck are you? So your advice to your patients is don't get old. That is by far the biggest risk factor that often people forget about when it comes to diseases like Alzheimer's disease. Is aging is the biggest factor. And in fact, again, the other question I usually get is why does there seem to be more Alzheimer's now than in the past? And of course, part of it's recognition, but the other part is just our society is aging, and because age is the biggest risk factor, we're going to see more and more of the disease. And in fact, if you look at the estimates by age group of what's going to happen as we get to the year 2050 here, you'll see this sort of explosion of 85-plus-year-olds. So those of us who are in the baby boomer years will be getting into that age group, and will really be driving up the frequency of dementia just because the risk is so high as you get older. Now, I used to think of this as sort of a first world issue, but it's really becoming a worldwide issue. And this is a study looking at Parkinson's, and again, another aging-associated disease, a disease that increases with age, and just based on the demographics that's changing around the world, an estimate of what's going to happen over the next 10, 15 years. And what you can see is in the blue are countries where there's an estimate of a doubling of the number of cases. In red is increase by more than double, and that includes Brazil, China, India, Pakistan, Indonesia. If you look this up on Wikipedia like I did, that's over half the world's population. We're going to see a more than doubling just over the next 10 to 15 years. So this is a world health issue now, and something that's not going to go away. It's going to be becoming a more and more problem as people live longer and therefore become at higher risk for these aging-associated diseases. So I thought I'd go through some definitions, and there are some new definitions out there. There have been a couple of papers that have come out of the National Institute on Aging Alzheimer's Association back in 2011. But the basics are pretty much still the same. Dementia still is a umbrella term, correct? So there are a number of different causes. Alzheimer's is the most common cause, but dementia is a general term. And certainly from a research perspective, as a physician, my diagnosis of dementia is based on two components. One is some sort of change in thinking skills that's happened, and that is sufficiently severe that it actually impairs function. And of course, function, that's a very subjective thing, right? If I have a patient who's a younger onset and is still working and they lose their job because of their cognitive change, that's pretty easy. If I have an 85-year-old man who's kind of used to having his wife take care of everything, it often is difficult to assess when that functional change has actually happened. So it could be somewhat variable, but you really need those two components for dementia, the cognitive change and that it's sufficiently severe to interfere with your ability to function on a normal day-to-day level. Alzheimer's disease, again, a subcomponent of the dementia. Obviously, they have to meet the criteria for dementia, needs to be insidious, and there are a variety of presentations that Alzheimer's can take. By far, I think, as most of us know, memory, particularly, the encoding of new memories, a short-term memory, is the most common presentation. So you're going to hear families say the patient has forgotten conversations, repeats themselves, keeps losing things. Now, there are variants. I've had patients start with fairly early language disorder, although typically it's in the context of also memory. I'll certainly have people have visual spatial dysfunction. They get lost very easily. People are driving, and I think there are a number of driving issues that come up, but certainly one of them is getting lost even in familiar locations. And where I was in Seattle, we had a couple patients that ended up on the other side of the state in the middle of farm fields because they got lost and they just kept driving until their car ran out of gas. And then you can have some executive dysfunction, so poor decision making, difficulty planning, difficulty multitasking. But again, primarily you're going to be looking for somebody with a short-term amnestic memory loss early on. We have started to get into the field of biomarkers. Certainly in our clinic, at the Cleveland Clinic, we do use these on occasion. We can look for particularly the changes that happen within the spinal fluid in terms of the tau and the amyloid, and I'll be talking about those in a minute. We might use an FDG PET scan to look at regional hypofunction. Structural MRI we use on pretty much every patient, and in fact one of the things I've enjoyed since I've gotten here is that we get a volumetric analysis on all of our scans to look particularly at the hippocampus, which is an area that's affected early in Alzheimer's disease. We can use genetics. If you have a young onset case with a lot of family history, they have a specific mutation, it really is diagnostic for the disease. We certainly need to do a lot more work in terms of figuring the biomarkers and how they're going to work out in the clinic, but it really is the future of Alzheimer's evaluation. So what's really going on in the real world? So the only way we can really know what's going on in the real world is to look at people after they've passed away and look at the pathology in their brain. This is a study that we did in Seattle based on the largest HMO in the Seattle area called Group Health Hospital. These were initial dementia cases that were then followed to death. Over 1,000 individuals volunteered for the study. About a third agreed to autopsy. This was our analysis of the first couple of hundred autopsy cases that came through. And I think at average age of death in this sample was about 85. So it really is pretty relevant to where most of the dementia in the real world is. And that's a problem with a lot of the research studies that you'll see published, is there's a tendency for younger patients to participate in clinical trials and in research. And so you get the average age of 70, which doesn't necessarily apply to the real world dementia that we see. So what we found was that it's not so simple. In blue here you can see people who fulfilled the pathology criteria for Alzheimer's disease. But if you look at just this little piece of pie up here, this is the group, only 14% that only had Alzheimer's disease pathology. We had a number that had Lewy body pathology in Alzheimer's, a number that had stroke, and actually we had a number that had Lewy bodies and stroke and Alzheimer's together. In fact, the same frequency essentially as pure Alzheimer's disease. So when you see somebody in your clinic and they are looking like they've got Alzheimer's, they're amnestic, it's progressing gradually, but you look at a scan and they have stroke, I often see people say, well, it must be vascular dementia, but probably more commonly what it is Alzheimer's with vascular disease. It's very common. In fact, if you combine these two, there are more people with Alzheimer's and stroke than Alzheimer's alone. So I think what we're finding is that in the very elderly especially, dementia is usually multifactorial. And this comes back, we'll talk about treatment, and I think Dr. Messinger-Rapport will talk even more about lifestyle changes. But in these patients, we know that the coexistent vascular disease contributes significantly to the dementia, and that's something you could control, right? You can control hypertension, hyperlipidemia, lifestyle changes, those sorts of things. So worth keeping that in mind, that there are things you can do for these patients. Another term that's certainly being used a lot more now is mild cognitive impairment. And what you really need for the MCI diagnosis is some sort of change in cognition, as you mentioned, an impairment demonstrated in some sort of test, but relative independence and functional abilities. Now, I've really not met many MCI patients that have absolutely no functional change, but generally speaking, they're still able to hold their job, they're still able to maintain independence, and in those individuals, we like to apply that term MCI. Now, the MCI term came about in part because there's a lot of interest in intervening very early in the disease, but also we're finding that some of these MCI cases don't convert to dementia in a relatively long period of time. So depending on how you exactly define MCI, you'll see studies say about 20–25% of patients at 5 years still have not converted to dementia. So it's not necessarily going to mean that you will in fact progress to dementia. And obviously we're interested in those groups, in those individuals, but the real, again, reason behind this diagnostic category early on was because we want to start intervening as early as possible and try to prevent the progression of disease. So what's normal aging? Well, what happens at about age 35, I'm afraid to say, and I know there are a few of you who are under 35, but is that your speed of retrieval starts to slow down. And then multiple neuropsychological testing, studies have really suggested this very strongly, that your ability to retrieve information slows down at a fairly early adult age. And, of course, what we do know is that as you get older, one of the few benefits of getting older is you do start to store a lot more information. You, in fact, do know more. You've had more experiences. You know stuff that people who are younger don't know because they just weren't around. And so, my excuse for myself certainly is that these file folders are very full now, and so it just takes me a while to get through them and pull that information out. But that's definitely something that happens, and that's normal. So, when you are trying to come up with somebody's name or a word and you're finding that more and more difficult as time goes along, that's pretty normal, and not so much what we see in Alzheimer's, which is really an inability to encode new information. So again, when you're trying to come up with that fact and it doesn't come to you for 5 minutes or so until after you're embarrassed, that's pretty normal. So what's Alzheimer's disease? Well, this is actually the first patient described by Alois Alzheimer, Auguste Dieter, and a picture of her that actually they found in his original records. And she was very young onset. She had onset, she was in her 50s with this picture. I don't remember the exact age of onset, may have been in the late 40s. Very recently, they were able to they found the paraffin blocks of her brain tissue that Alzheimer had used to describe the pathology that I'll show you in a minute. And we're actually able to extract the DNA out of that and found that, in fact, she had a mutation in a gene that we know is linked to early onset Alzheimer's disease. So we now know that she had the early onset partly because she carried this mutation. After she passed away, Alzheimer did examine her brain, and I think fortuitously, and he happened to be using a silver stain that we still use today to look at fiber tracts in the brain, but it also happened to pick up the major pathologies of Alzheimer's disease. And so he described, in fact, what we still use today to make a diagnosis pathologically of Alzheimer's, which are these tangled bundles of fibrils, or the neurofibrillary tangles, or sometimes just tangles, and these deposition of a peculiar substance, which is the amyloid, or A-beta, or beta amyloid. So we really, right from the start, describe very nicely the changes in the brain that we now, again, use to make a pathological diagnosis of Alzheimer's. We use a variant of the same silver stain that he did. He actually was really a brilliant pathologist. He described changes related to hepatic encephalopathy in the brain, and also the Pick bodies of Pick's disease he also described. So he really was very important in early brain disease pathology. So here's a silver stain that we've done on two individuals, one who died without Alzheimer's. Obviously they died from something else, but they didn't die from Alzheimer's. And somebody who did die with Alzheimer's, and you can see all these plaques that are very easy to see, even at a low microscopic power. If you go a little bit higher power, you can see these plaques, and you can also start to appreciate the brain, the neurons here also contain this dark material. So we really have the plaques and the neurofibrillary tangles that we can see here. So there's certainly a classic looking cortical pathology for Alzheimer's disease. If we go a little bit higher power into the plaque, you see a variety of changes. We often call them neuritic plaques because there's actually processes of brain cells, of neurons, passing through that are distended, often filled with a lot of degenerative material, and we call these neurites. But importantly, what you want to look at is this little brown material in the middle, which is the beta amyloid protein, or BAP we might call it. And this has really been a focus of Alzheimer's research for the last 20, 30 years, the so-called amyloid hypothesis for Alzheimer's, the feeling being that this really gets the process going. And I'll talk about why we think amyloid is so important in the disease, and why we think it plays a role in the pathology or pathogenesis of the disease, but that is something you want to keep your mind on here. So the amyloid, the BAP that we see deposited in your brain in Alzheimer's, comes from a precursor protein that we all have, and that precursor protein is actually on chromosome 21. And we know now that some of the mutations, in fact the mutation that Auguste Dieter had, was actually at the site where this precursor protein is broken down to make the beta amyloid. So something about the mutation changes the way and it tends to drive this pattern towards the abnormal A-beta being deposited in the brain. That was the first sort of genetic clue. The other genetic clue that we've actually known for a long time, this is on chromosome 21, and as many of you may know, people with Down syndrome are particularly high risk for Alzheimer's. Essentially, if you look at the brain of somebody with Down syndrome over the age of 35, they all have Alzheimer's disease pathology in the brain. Pretty much 100%. It would be a case report in the literature if you didn't see that change. And basically the only genetic change the Down syndrome patients have, they have 3, right, chromosome 21s instead of 2. So they have 3 copies of this precursor protein instead of just 2, and just having the 3 copies drives them to 100% risk for Alzheimer's disease. That's certainly one of the strongest genetic connections linking this amyloid to the pathology of Alzheimer's disease. As we'll go later, we'll talk a little bit about the immune therapies that attack the amyloid, But there have also been attempts to block the enzymes that break down this precursor protein to make this BAP protein. So particularly there's a lot of interest in what we call beta secretase inhibitors. So that's the amyloid. The other major change we see are the tangles in the brain cells, the neurofibrillary tangles, and this is a drawing by Alzheimer from Auguste D's autopsy showing these tangled bundles of fibrils in the brain cells. Here's another slide from my own lab showing the fibrils just densely packed within this neuron. That neuron should look like this guy over here, relatively free of these fibrils, but these guys all have neurofibrillary tangles in them. And as you might imagine, these cells don't work very well when this aggregation occurs, these tangles occur within the neurons. So we know that it seems as if amyloid kicks the disease off, or at least that's the major hypothesis right now. But we also know it's not until the tangles appear in the neurons that people actually start to have clinical symptoms of Alzheimer's disease. So many people have argued, and it's a reasonable argument, that if you could stop the tangles from forming, who cares how much amyloid you have in your brain? Probably people wouldn't have any cognitive changes. So there is a small literature, not as big as the amyloid, of trying to block these tau aggregations from coming together, these neurofibrillary tangles. So in the amyloid, in the plaques, we have the beta amyloid from chromosome 21. In the tangles, we have a protein called tau, or TAU, and that's very relevant to a variety of things that I'll be talking about later. This is a different chromosome, chromosome 19. There have been no mutations in tau that have been linked to the development of Alzheimer's disease, which again suggests that this is not a primary mover of the pathology of the disease, but it does relate very strongly to what kind of symptoms you have, in particular that you have symptoms. I will be testing you later on this, but on the tau gene, but I do want you to remember the tau protein. So there are pretty strong feelings about these hypotheses, and we often think of them almost at levels of religion. We have the Baptists and the Taoists, and I'll get back to that a little bit later. So let's get back to the clinic. So you know a little bit about the pathology in the brain. From my perspective, certainly, when I'm evaluating somebody for dementia, by far the most important component is the history, particularly usually from an informed source, a family member or some other caregiver, because certainly for Alzheimer's disease, most patients lack complete insight. They may recognize they have a memory problem. Often they'll usually tell me that I have a problem retrieving names and words, like we all do. But they won't recognize that they're not remembering things, and that's just a part of the disease. They lack that ability to recognize their own deficit. It's not a denial. It literally is a biology and neurology of the disease. So you do want to get a careful history from some other informed source. Everything else kind of relates to that. I'm going to do some kind of bedside testing. I may get a formal neuropsych evaluation to sort of confirm what I'm hearing. You know, one of my favorite stories is I had a patient that came in with a frontotemporal dementia, clearly had the language-based type frontotemporal dementia. I was seeing him. I went to talk to the family, and I said, "What was the first symptom you saw?" And they said, "Oh, he had a memory problem." And I go, "Really, a memory problem? This really looks like a language problem." They go, "Yeah, he forgot how to speak." So from their perspective, it was memory. And you'll see people say memory, and you really want to delve into that a little bit more, into what do they exactly mean, because memory can be used for everything, and people tend to think of everything related to memory. So in terms of history, typically what I'm going to work on, again, is focused particularly on that short-term memory. Are they having trouble encoding information? Because that's really the really characteristic aspect of Alzheimer's disease. Generally speaking, retrieval is going to be about the same as what we all experience as we get older, and that sort of immediate working memory often is pretty good early on. Now, other diseases like Parkinson's disease, where there's actually a fairly high frequency of dementia, often attention and working memory is the biggest problem. People tend to get off track more easily, can't multitask very well. Again, in Alzheimer's early on, particularly that attention and staying on track is okay, but if you just, you have some sort of interference and you come back to something, they can't remember what they were doing or who they were, some of the facts. They cannot encoding and holding on to that information. So, sometimes I have patients, I think was just talking with Barbara here, and we were talking about when patients show up. In our community-based study of Alzheimer's disease, people were actually showing up, on average, their mini-mental was in the low 20s. So frequently, particularly in the elderly patient, they'll show up relatively far into the disease, surprisingly far. Now you're getting a little more sensitivity to the disease in the community, but you generally often don't get people bringing in a patient until something beyond memory loss occurs, because they'll often say, well, I thought that was just normal aging, and it wasn't until we realized that he wasn't paying the bills on time, or that he was making bad decisions, or he started to be incontinent. Those sorts of things really get them in finally to be evaluated. But at least by history, I'm going to listen for that kind of memory loss. Are they having trouble encoding information? And, the family will often say, he remembers, who sat behind him in first grade 82 years ago. And I said, well, what about recent memory? And they go, well, in the car he asked me, half a dozen times where we were going, and I told him, and then 5 minutes later he asked me the same question again. So you see that discrepancy between short-term and long-term memory. Behaviorally, often apathy is the first symptom. You think about agitation, but often it's that loss of drive, internal drive. I was talking yesterday to the public group, and I was talking about my mother when she first got Alzheimer's disease, very involved in the church. Every day was down at the church there at some sort of activity, music club, and the knitting club and all these things. And she just stopped going to these, just gradually less and less active. And it wasn't that she was depressed, she just didn't have any internal drive. And you'll have families come in and say, I think he's depressed because he sits in a chair and looks out the window all day. And you say, well, but is he anhedonic? Can he still enjoy himself? Oh yeah, we go and see the grandkids and he likes that. And he goes out, but there's no internal drive to do this anymore. It's a very common early subtle symptom that the families will often mention to you. I've already talked about poor insight, and some about visual spatial skills. As the disease goes along, it becomes more generalized, so you're going to get some executive dysfunction. You're going to start to sometimes get cortical dysfunction, so language disorders can happen. People can have trouble figuring out how to use their hands, or apraxia, or they may have trouble processing visual information. I've had a number of patients where the family comes in and says, we've changed his eyeglasses multiple times this year, but he still doesn't seem to be able to see. And I'll check their acuity. It's 20, they can read just fine, but they have trouble finding objects in their visual field until suddenly it kind of clicks in. And it's because their processing of visual information is impaired. So something to think about after they've purchased 3 or 4 new pairs of glasses over the last year. Obviously, you can get more severe behavioral disturbances as you go along as well. So after I get a decent history and I'm thinking, well, gee, this could be Alzheimer's, I have a lot of short-term memory loss, maybe some apathy, then I'm going to try to do some sort of bedside test. The standard up until pretty recently has been the mini-mental, which has its positives, which mostly is that everybody has used it, kind of knows what a score means. And so it's valuable from that perspective. There's some cons. I don't like the fact that its short-term memory task is very short, right? It's 3 items and then just a small interference and then you come back to it. So I've had smart individuals who will literally in the back of their mind repeat those 3 words over and over while they're doing world backwards or serial 7s, and they get the 3 words correct. It's really a very easy short-term memory task. But the major change that's happened is a company bought the rights to the mini-mental about, half a dozen years ago now, I think. and started charging larger institutions and studies for using it. And so you've seen a lot of groups like the Cleveland Clinic, where I was in Seattle at the VA. We're no longer using the mini mental and have moved something called the MoCA, which I'll talk about in a second. Another test actually came out of a colleague in Seattle is the mini cog, which is, I think, a kind of a decent screening measure. And this is basically asking somebody to repeat 3 words to you, drawing a clock, and then asking them to come back to those. Now, it doesn't tell you a lot about what's going on, but it is a nice little screen for people who have sort of mild to moderate dementia and will struggle with it. Again, not a lot of detail, but again, it's a screening method, and it just takes a couple minutes to do. Kind of have very practical implications. Clock drawing is a science in and of itself. You see a variety of different clock drawing scoring sheets and so forth, and I only throw this up because this is my favorite clock from clinic. And so I was working with a resident, and he said, you know, I think I asked him to draw a clock face. And so that's what he did. You can see he switched from analog to digital here. I asked him to put in 820, but struggled with that. I did see this guy about a year later just to see if he'd spontaneously do this, but he spontaneously drew a poor clock, actually. But anyway, my favorite clock. And I'm not sure how you would score that, but... So the test that a lot of people use more and more now is called the MoCA, or the Montreal Cognitive Assessment. Number 1, it's free. Number 2, it comes in something like 35 plus languages now. So for example, I know there's a Portuguese version and a Brazilian Portuguese version. It comes in Arabic, which we've used at the Cleveland Clinic. So it has a lot of benefits from that perspective. It's more difficult than the mini mental. So you kind of have to get used to having people do it, because a lot of people will miss a couple of points on it. It has a very difficult short-term memory task. But it is something that is more sensitive, has more executive functioning, so it picks up non-Alzheimer's a little bit better. The norms are somewhat limited, so again, you kind of have to get some experience with how people do based on their education background and age. And it takes a little bit longer. In fact, I'll go straight to it. This is the MoCA here. It's free, so you can go to mocatest.org and download whatever version. They even have different versions, so if you're worried about repeating it frequently, you have different versions that have, for example, different animals. So what animal is this? Oh, rhino? Okay, I heard a few murmurs. So I don't know, I must say 50% of my patients say hippopotamus, if not more. And occasionally I hear giraffe. But I don't know what it is about the rhino, but people really struggle with it. Anyway, so it has a sort of an executive function, what we call a trails test, where you can alternating between numbers and letters. A more difficult, there's something about the three-dimensionality of the cube versus the intersecting pentagons of the mini mental that really makes it much more difficult for people. And I've had Parkinson patients where they have a lot of visual spatial difficulties say, you know, the cube keeps moving, and so I can't copy it because I can't figure out which direction it's going in. There is a clock drawing task. You have them repeat 5 items 2 times, and then you go through all this before you come back to those 5 items again. And so you have to be careful. Some people, you ask them for 5 items, they go, oh God, I don't know. And they just shut down. And so you can, although it doesn't go into the score, I like to give cues, category cues. Okay, it was a color, and they go, oh yeah, it was red. And you go through that, and it turns out they do remember. They were encoding that information. They just sort of blanked out. But for my Alzheimer patients, you know, even with cues, a lot of times they just don't remember. And another part of memory is just orientation. Do they know where they are? Do they know why they're here? That sort of thing. So it's a nice test, and it's something certainly I think most of us in the dementia field are using now. So general exam, I'm going to do a neurologic exam. Again, it's not a surprise if I, on exam, find something that suggests they might have had a stroke. Doesn't mean they don't have Alzheimer's and a stroke. From a laboratory testing point of view at this point, I typically do this little set up here. It's pretty rare. In fact, it's been a long, long time since I found something that's a primary cause On the other hand, not unusual to find somebody who has, say, hypothyroidism that hasn't been adequately treated and is aggravating the dementia that they have. So it's worth exploring that. I can do genetic testing. I typically do that in the context of an early onset, so under age 55 to 60. I'll probably always at least discuss genetic testing. I might get a genetic counselor involved, or particularly if there's a very strong family history. We do sometimes do CSF, or cerebral spinal fluid testing, and particularly you can measure for those amyloid and tau proteins linked to pathology. Interestingly, the amyloid levels actually go down in the spinal fluid with Alzheimer's, the thought being that it binds to the plaques in the brain, and so therefore it doesn't get leaked into the spinal fluid. On the other hand, tau levels actually go up, and the thought there is that the brain cells are dying and they're releasing that tau protein into the spinal fluid. So you see them going in opposite directions, which is actually helpful because we use the ratio of the two to help us make a diagnosis of Alzheimer's disease. You can look for other things, infection, proteins, both tau and 1433 are linked to Creutzfeldt-Jakob disease, sort of mad cow disease. You can look for paraneoplastic markers if you want. So there are a number of things you can do with spinal fluid. I pretty much always do some sort of structural image. Again, I like MRI because you get a little bit more volumetric data out of that. Can do a spectra PET scan, which can be sometimes useful for looking at regional glucose utilization. And now there is amyloid imaging available called Amyvid, which can pick up the amyloid deposition. There are a couple of caveats there. Number one is it generally is not paid for by insurance, and it costs somewhere in the $5,000 to $7,000 range. So if your patient has, $5 to $7K in the pocket, that's great, but most people don't. The other caveat is we're finding, kind of like MCI, that a number of people, elderly individuals who have no dementia, have amyloid deposition in their brain and haven't gotten demented in the time that we've followed them. So as a predictor for dementia, it's been a little bit, it does increase your risk for progressing to dementia, but it's not clear that everybody does progress to dementia. So there's some caveats with that kind of imaging. This is just a typical, what you get if you send a spinal fluid off for tau and amyloid to Athena Neuroscience, who does this for you. What you see is the low amyloid and the high tau, which is in this lower square, are people who typically have Alzheimer's disease. Interesting that Creutzfeldt-Jakob, or mad cow disease, you see these extraordinarily high tau levels. The idea being there's so much neuronal loss, so much tau being released into the spinal fluid that it's really driving it up. So it's very, very, very atypical look to it, but actually helps a lot in terms of diagnosis. Hippocampal volume, as I mentioned, so what you can see here is a normal brain with a normal hippocampal volume, and here you can see in somebody with Alzheimer's disease that you see significant atrophy there. And for those of you who don't know, the hippocampus, the primary purpose of the hippocampus is to encode new information. It really gets all these sensory cortices actually feed into this region right outside the hippocampus called the entorhinal cortex. That feeds all that sensory information through a loop in the hippocampus. So it's basically pulling all this information in, and then by running through the hippocampus, it allows you to encode it so that you can hold on to it for more than a couple of minutes. And that's really where the pathology is in Alzheimer's. What we know, partly because from the seizure surgery literature, is that you have to knock out both hippocampi to really knock out memory. So again, it's very unusual for a stroke to cause that kind of short-term memory loss because you'd have to hit both sides of the hippocampus. We know this because in seizure surgery, typically they take out one hippocampus frequently, and people have relatively normal memory. But there is this poor guy, HM, back in the 50s, one of the first seizure surgery patients, where they removed both of his hippocampi, and when he woke up, it was like he had Alzheimer's disease. He remembered his family members, but he couldn't put any new information in, and there's a whole literature studying this poor fellow. And then, as I mentioned, you can look at FDG-PET, which kind of measures glucose utilization. And you can also look at this new amyvid or amyloid scan, which picks up whether there's amyloid deposition in the brain. And these are new sort of imaging techniques. So treating the dementias next. And this guy says, I took a ginkgo pill to boost my memory, a diet pill to boost my energy, and a ginkgo pill to boost my memory. So ginkgo hasn't worked out so well so far. But I do think when I'm looking at new trials and trials related to treatment of Alzheimer's and dementia, it's always good to think about the whole disease, not just the cognitive aspects, but the behavioral aspects, the impact on activities of daily living, because those are the things that really often the behavior in the ADLs that really drive the disability. A lot of families say, if I could just stick with the short-term memory loss, I could deal with this. But if they're having behavioral issues, they're not sleeping, or more and more they can't do things around the house or things that they normally took care of, that's where a lot of the disability comes from. Of course, most of us are familiar with the cholinergic drugs, Aricept, Exelon, and Razodine. Pretty much these drugs work an awful lot alike. They're modest in their effects, and probably the only difference between them, they all come in once-a-day dosing. The Exelon does come in a patch form, and sometimes that's useful. It has less GI side effects, although it does have more, as you might imagine, skin side effects. So sometimes I'll choose between these drugs really based on whether it's going to be better to give them a pill or use a patch. All of them have, in double-blind, placebo-controlled trials, showed people are better on drug than off drug on cognitive testing. And this is a ADAS-Cog, which is a typical scale that is used for for clinical trials in Alzheimer's. And what you can see is people on drug are better than people who are on placebo after 6 months of time. Now this difference is relatively small. This is a 70-point cognitive scale. So you're seeing anywhere from 3 points to 7-point differences on these studies. So it's a modest effect on cognition. And actually my experience, my anecdotal experience over the many years has been the major improvement is not in short-term memory, that encoding memory, but working memory, that immediate memory. So families are going to come back and tell you, you know, he's better around the dinner table, he follows conversations better, but he doesn't remember the conversation any better, 20 minutes later. So they're a little bit more engaged. I'll talk about the behavioral effects, but they're more engaged. That sort of immediate stuff is much better, but the delayed things aren't all that much better. So this just kind of goes to the behaviors. Over and over again, these trials have shown that people on drug are better behaviorally in that apathy. They come out of their shell a little bit more. So again, they're more interactive around the dinner table. They're more able to follow directions sometimes immediately, but they're not going to remember that much better later on. So those are the major positive effects. From an ADL, activities of daily living point of view, they don't really get any better. And basically what you see is they decline slower on their ADLs. And this is a problem because families come back and say, well, he's still struggling doing the bills and things like that. And all I can tell them is I know that in the treatment trials, when people took a sugar pill, they weren't quite as good as people who were on drug, although you may not see a big difference, practically speaking. Major side effects are usually gastrointestinal, nausea, anorexia, diarrhea. Probably in your very elderly patient, you just want to make sure, sometimes they won't complain of nausea, but they'll just stop eating because they don't feel hungry anymore. And so you do want to watch for weight loss with these medications. Slowing heart rate, dizziness, agitation are pretty uncommon. I'd say agitation I mostly worry about in people who, these drugs are a little bit activating. Again, they bring them out of their apathy, out of their shell. If you have somebody who's already way out of their shell, like some of the frontotemporal dementia, behavioral variant kind of patients, bringing them out of their shell even more isn't really a great idea. So it is something that you do want to be a little bit careful with. So overall, I think of the cholinergic drugs as, to improve modestly people over 6 months to a year period. We don't have a lot of long-term data. Our suspicion is people continue to be a little better on drug than off drug, but they will, continue to decline. There is some help with behaviors, particularly apathy, and there's some data that it may delay placement in long-term care facilities, although this is a very, very subtle change. The other drug that's available, FDA approved, is Namenda or memantine. And this is working on a different system. This is working on the glutamate system. So the cholinesterase inhibitors are really trying to increase the acetylcholine in the brain. Memantine is really trying to block the glutamate. And the idea being that glutamate is overactive in Alzheimer's disease, and in fact, that it's leading to neuronal damage and death. So there was a lot of hope when Namenda first came out that in fact going on this might actually have not just some symptomatic effect, but actually have an effect on progression of the disease. Unfortunately, with treatment trials, we've realized that the drug, while it has a modest effect on cognition, in the placebo-controlled trials, when people went from the sugar pill to open label, they come right back to where the people who've been on drug all the way along are, suggesting there's no disease-altering effect of the drug. So it really is a symptomatic drug. I think most of us use this drug in a combined method, so we often start somebody on Aricept or Exelon or Razidine, and then later we'll add Namenda on top of that. There is some evidence, this is a trial looking at people on long-term Aricept alone, or people who had Namenda added on top, and you can see they got a little bit of a boost, and they're significantly better than people who are on Aricept alone. So we often think of this as a sort of an add-on drug. Now, behaviorally, Namenda has a bit of an effect, particularly actually on agitation and aggression. There has been shown in several studies to reduce sort of emergence of worsening agitation. So while I wouldn't consider it a drug I put somebody on for agitation, it is a drug where if I know they're on it, I've probably lowered the frequency of agitation a little bit. So it's a good drug to have as sort of a foundation of treatment. So it's indicated for moderate to severe Alzheimer's. There is some evidence that it works in other non-Alzheimer's diseases. I will use it occasionally in monotherapy if somebody can't tolerate cholinergic drugs at all. But generally, I'd say most of the time I use it as an add-on and with a kind of a side benefit that maybe it reduces agitation a little bit. I do think it's important that we sort of look at non-cognitive therapies, look at other kinds of interventions. There are a number of non-pharmacologic and medications. I think Dr. Messinger-Rapport is going to go into some of this. As I like to mention, apathy, the cholinergic drugs can be somewhat useful. I have not used a lot of psychostimulants. I haven't felt like the apathy is to the level where I really need to intervene with it. Irritability can be a frequent problem in Alzheimer's, and I often call that sort of reactive irritability. So the patient is fine if you leave them alone, but if you try to get them to take a shower for the first time in a week, they're really going to resist you, right? So, and often I see antipsychotics used there, and I really try to avoid those. I've often liked antidepressants will often take the edge off of that sort of reactive irritability. And the nice thing, it's not sedating, doesn't have a black box warning, and usually it's my first line medication. Some people like to use anticonvulsants. Again, I tend to avoid those only because they're sedating. Probably people don't think quite as well on them. And I really resort to the antipsychotics in the terms when the agitation is really out of control, and particularly when it's not just reactive agitation, it's just this constant outflow. Now, if somebody has actual psychosis, they're hallucinating, they're acting on delusions, they're calling the police, they're accusing the spouse of being an imposter, these sorts of things, I may end up using an antipsychotic in that situation. Certainly right now I tend to use quetiapine or Seroquel as my first line drug. Frequently these patients are really severely agitated or psychotic. The nice thing about quetiapine, it is sedating. Give it at bedtime, they sleep a little better. Nothing helps a caregiver better, right, than having a good night's sleep. So certainly one of the things I usually do when I start the quetiapine is add the doses at first at bedtime. Sleep is often, as I said, an issue. I try not to treat it directly. I try not to use a lot of sedative hypnotics. What I frequently find is that the sleep hygiene, if you get a decent history, is the major issue. So you talk to families, especially if they're in a nursing home. I hate to say it here. I don't know what time you put your patients to bed here, but sometimes they're putting them to bed at 7 o'clock in the evening, and it's still light out a lot of times. And at home, you'll see the families will try to do that. They'll say, well, he gets up at 8 a.m. and he takes a 2-hour nap in the afternoon, sometimes even a second one later on, and we put him to bed about 8 o'clock. Well, by midnight or 2 a.m., he's had 8 or 10 hours of sleep already. No wonder he's wide awake. So trying to reduce the daytime napping, try to maybe extend the evening a little bit. If you're on medications, try to make the sedating medications towards the evening to try to get back to a normal sleep pattern as much as you can. So, Maria, are you still driving? So, certainly driving is one of the biggest issues that agitates my patients. Generally speaking, my approach used to be, gee, you're at increased accident risk, aren't you worried? And the family say, no, he won't get in an accident. He only drives around the block, and we're not worried about that. So I've brought in the legal risk, and that seems to actually work pretty well. So typically what I will talk to people about is say, he has a documented memory disorder. If he gets in an accident and there's any legal issue, he's going to be blamed no matter what. And one of the unfortunate circumstances I had early in my career when I was training in Chicago is I had a patient pulling out of his driveway, right? So he's just driving locally. He's driving down his driveway. A kid was speeding down the street, hit the back of his car. They sued him and they won, even though the kid was speeding. Because they said, how do you know he wouldn't have made a better decision? There's no defense against that. So typically what I tell people is, if you've got a memory disorder, if you've got a dementia, you either have to stop driving or you at least need to have your driving evaluated. And some will pass, but at least they have some legal protection at that point to help them. And it's nice if you can help them explore options if they can't drive. And it's difficult. Certainly, you have people who live in fairly rural areas. You have spouses that have never driven or driven very little, feel very uncomfortable, or a spouse who's just as demented as the patient. And so it's good to try to get some help in figuring out options. So where do we go from here? I'm going to kind of speed along here. Biomarkers we've talked about. Yogi Berra says you've got to be very careful if you don't know where you're going because you might not get there. And biomarkers are really all about that. We're trying to develop better ways to measure in blood, spinal fluid, brain imaging, what's happening with the disease, particularly as we start to try to move to treating the disease process itself. Biomarkers can come from blood, urine, we've even done a spit study, spinal fluid, neuroimaging. These all can be used as biomarkers. And my guess is we'll probably end up using multiple ones. And I didn't throw this up here, but genetics can play a very important role. We know now that people who carry the E4 risk factor for Alzheimer's seem to respond to therapies different than people who don't carry the risk factor but have Alzheimer's still. So we're finding that these biomarkers, much like with cancer, can tell you what kind of therapies are going to be most useful. So if we go back to the Baptists, that's where, again, where a lot of the focus has been in trying to treat the amyloid in the brain. As I mentioned, this is coming from a precursor protein, and I'm not going to talk too much about it. One area of work has been to try to block these secretases that actually make this amyloid. The gamma secretases turned out to be a little too important in a variety of different bodily functions, and people have not tolerated them very well. But there is a lot of interest in these beta secretase inhibitors to really block this breakdown and kind of drive this equation more in this direction. A lot of the real work has been done in trying to use the immune system to attack these amyloid plaques and get them out of the brain. And a lot of this actually comes from mouse studies. And this is a picture of Nature from a while ago, 1990s, early 1990s, that really showed that they could take a mutated amyloid gene, insert it into a mouse, and the mice would get plaques like you see in Alzheimer's disease. So this is a big breakthrough because it allowed us a model with which to look for new drugs to treat amyloid. And in fact, one of the first trials that came out was a trial that was published in Nature in '99, actually showing that if you immunize these mice against amyloid, you can actually get rid of the amyloid in their brain. So if you can see the data here, these are animals, transgenic animals, lots of amyloid in their brain, and here's these animals treated with a vaccine. All the amyloid is gone. And really at the time when this came out, I think most of us thought, gee, we're going to have to start looking for new jobs because this is the cure. And again, if you're transgenic mouse, this is definitely the way to have your Alzheimer's treated. Pretty quickly thereafter, went to clinical trials to vaccinate people against Alzheimer's. And unfortunately what happened is you stimulate the immune system to attack this amyloid. It attacks not only the amyloid and the plaques, but the other amyloid you produce. And about 10% of patients developed a pretty severe meningoencephalitis. And in fact, were significantly medically ill. And in fact, the trial had to be stopped because of that. But there was some evidence. A few people died, and at autopsy actually were missing plaques from their brain, suggesting that this actually was engaging the target. So what you've seen since then is a variety of drugs developed to not vaccinate people, to actually infuse antibodies to sort of simulate the vaccination, but it allows you to control that because the antibodies have a short half-life. You can stop infusing them if people develop an encephalitis. Really gives you better control. The problem with most of the trials so far is that they've been mediocre in their outcomes. So in the solunizumab study, what you saw, the primary outcome, which was the ADAS-Cog scale I showed you with the cholinergic drug, didn't really reach statistical significance. There was a little bit of evidence that we're engaging that amyloid target here, but we haven't really seen with these drugs a significant effect on cognition. Now, one of the arguments has been, well, we're treating mild to moderate Alzheimer patients. The damage has been done. The amyloid is very important very early in the disease, so we need to treat the disease earlier. And so there are a number of studies that are now starting to enroll looking at early disease or people who are at risk for disease. And two of them are actually picking people who have mutations like GUS-D did, the presenilin 1 or presenilin 2 mutation, or mutation in that amyloid precursor protein, and treating these people who we know will get the disease, essentially 100% risk, but they haven't developed the symptoms yet, trying to intervene early in the disease. Two other studies have looked at people who carry a risk factor, risk gene for Alzheimer's, or who on amyloid imaging, those normal elderly who have amyloid already in their brain, and intervening with them. So these trials are really trying to identify people early, even before clinical symptoms, attack the disease then, with the idea is that when we need to intervene. And we'll see. These are all just getting started, so it's going to be a few years before we really know how they turn out. There are other therapeutic approaches, and you know, you go to trials.gov, and you'll see hundreds of clinical trials that are out there that are being done, ranging from vitamin supplements, estrogen still being looked at. Exercise is, I think, one of the better non-pharmacologic interventions that really seem to be having a significant effect. And you'll see even some trials now starting to look at things that treat, for example, agitation. We have a number of studies we're doing. Our Hilda Sosik over here, our coordinator, is helping us manage several clinical trials that we're doing, ranging from a plasmapheresis trial to try to treat really the immune system in Alzheimer's, transcranial magnetic stimulation. We just got a grant from the Alzheimer's Disease Drug Foundation to use rasagiline, which is typically used in Parkinson's, to treat dementia and Alzheimer's disease. and we have some non-treatment trial studies we're doing as well. I'm going to skip ahead because of our time. But I'm just going to stop here and just say don't forget help is available for yourselves, for your patients. The Alzheimer's Association is always a great resource. There's several clinicians, including ourselves, that do dementia work that can help out in the community. And if you or you know people who are interested in research, please let us know. So thank you for your attention. So are we going to take a break here? We got kind of a late start. Or are we just going to? Are there any questions? Yes, ma'am. You know, so the question is about Down syndrome and sort of life expectancy. So what happens is by about age 35, you see about almost all patients have the pathology of Alzheimer's in their brain. By about age 50, you see about 50% have clinical symptoms of dementia. One of the data points that suggests the pathology goes on a long time before the symptoms kick in. Duration, or how long people survive, is really quite variable. I've seen people survive into their 60s and 70s, certainly not 80s and 90s, at least in my experience. And the other interesting thing is I don't think we have real good data. It's very hard to test Down syndrome patients because of the disability. But my perception is a lot of them go very slowly with their dementia. I've had patients go 10 and 20 years with symptoms that are gradually getting worse and worse, but are still doing okay. But I don't have really good survival data.
And my second question is medications that are used to treat dementia.
Mm-hmm.
What's the stopping point for them?
Stopping point, that's a very good question. And because they have some behavior, the drugs that we have available have some behavioral effects, typically personally I'm going to stop them when behavior is no longer an issue, when people are so debilitated by their dementia that they really don't have behaviors that we're really trying to control anymore. For example, if they're pretty much spending most of their time in bed, that sort of thing. One of the things I do argue against that often upsets me is when a patient moves into a nursing home, often you see these drugs stopped immediately, and if they're getting agitated when they first get into the nursing home, you don't know if it's because you stopped their drug, because they're in a new environment, or, a variety of things. So at least for the first period of time, I probably like people to be kept on the drugs when they first move in, just so that you know what's causing what problem. Is there a question over here? Yes, sir.
How far are we away from a cure? And where would you like to hope to see a cure?
Oh, well, I'd like to see a cure today. I don't know. I don't know if this is going to be like cancer, where we're just going to plug along and there's going to be very small incremental changes over many years. I trained in New York City in the late 80s and with HIV, and all my patients died. And while we don't have a cure, we certainly have a major alteration in the intervention. It's become a chronic disease, not a mortal disease necessarily. So I don't know, and HIV changed over a period of a very short period of time. So I think one thing I do know is if we don't keep plugging ahead and keep trying things, we won't get to that, major modifier or that major cure. Yes, ma'am.
Do the tangles appear throughout the entire brain or just in one section?
Oh, somebody asked me that question yesterday, and I'm surprised because I haven't been asked that question very often. So it's a good question, and they do occur in specific areas. The first area really is that hippocampal area that's so important in short-term memory, and that's why our assumption is that short-term memory is sort of the first symptom of the disease. But there's some areas that never get tangles at all, and so it is very regional, and we think it's related to the kind of symptoms that you have. So for example, the variants where there's a lot of, say, language impairment, we tend to see the language areas more involved, or the ones that have more visual problems will have the visual cortex more involved.
So you couldn't do like a brain biopsy to diagnose Alzheimer's?
You can. We don't, because it doesn't change management too much. But we do have these amyloid scans, and there is experimentally now tau scans to start to help us. So that's kind of what biomarkers are, sort of a way of trying to biopsy the brain to figure out exactly what's going on. And I think that'll be very more important because if some of these interventions like the antibodies work, you know, these are expensive, you have to infuse, there's significant side effects. We're really going to want to know that people have the disease before we put them through this process. Yes?
Where do you think the word senile and hardening of the artery come in when people talk about dementia? Very often when I'll get a history, family might say, well, my grandmother was senile.
Right.
Or, you know, I always heard she had hardening of the artery.
Right. So, I think we found that a lot of people who were called, well, senile just referred, there were senile and pre-senile dementias, and senile was sort of a broad term for older onset dementia, and could have been a variety of things. Most often it's Alzheimer's, but could be a variety. And, remember the hardening of the arteries was sort of that 50s and 60s when we were also focused on heart disease, vascular disease. A lot of those patients at autopsy, while they can have stroke, often end up having Alzheimer's disease. So it's just that the era in which we didn't have a good knowledge. It was really in the 60s that people finally started doing autopsies in dementia patients, and a lot of these, again, hardening of the artery cases turned out to have Alzheimer's disease. And in fact, because of the original patient, it used to be thought that most Alzheimer's was young onset and it was a fairly rare disorder. It's only been in the last 40, 50 years that we've really recognized how much a role it plays in what senile dementia, so to speak.
Okay, good. Last question.
I think they're okay. Go ahead. Yes, sure.
Thank you. Lovely presentation. I'm curious that there are a number of programs now online that do cognitive kinds of stimulation, like luminosity, relay, those kinds of things. How effective are those?
So our question is about these sort of cognitive, testing, luminosity enhancers. I think we don't know yet. I've certainly always argued, well, number one, we know they don't hurt. So other than your pocketbook, if you're using certain kinds. So I do encourage people to get out, be social, be cognitively interactive, but we don't know exactly what the impact is yet. I think exercise, in my mind, has a stronger data behind it, but I do think people do better when they're socially interactive, so I generally recommend. And because of the apathy, it's often hard to get people out, so I try to get people scheduling activities, scheduling exercise, because if they've paid for something, then they're more likely to go do it, that sort of thing. Or if they have a group of people waiting for them and asking them, why weren't you there last week? It just drives them a little bit more to be active. Okay, well, thank you very much.